Radiotherapy treatment planning works by trying to add up a high dose of radiation in the region where we know there's disease in the body.
But the downside is if we give too much radiation to too large of an area where we're actually treating more normal tissue than tumor, then the patients actually have more side effects and it defeats the purpose of treatment.
The limitation with radiotherapy treatment up until now is that there was no way to tell that you actually had the best plan. ECHO gives us the best plan.
ECHO is a completely different paradigm. It's very high precision, focused radiation treatment.
ECHO gives us very precise control about how the radiation conforms to the shape of the tumor and avoids the normal tissues.
And so we're able to give more effective therapy with less side effects, which results in better outcomes.
I was first introduced to Dr. Yamada in the fall of 2017 when I was diagnosed with 3 spinal tumors. Once he gave me the medical assessment, he actually put his hand on my knee and said, "Just so you know, I've got this," which kind of was, still gives me shivers. Today, to say that. But 6 months later, he was delivered on his promise after the treatment plan, and we had no evidence of disease in my spine after the radiation treatment that he put together. So unbelievably grateful.
The idea of ECHO was to formulate the problem mathematically.
The goal is to produce optimal plan for individual patient through automation.
So we needed some mathematical model that represents both physics of radiation and also the clinical criteria set by the physician.
At the end, we realized the fundamentals are very simple.
We created a software that is also seamlessly integrated with our current FDA-approved treatment planning system.
Patients get a better treatment plan and they get it sooner.
ECHO is a software that improves radiotherapy and improves cancer care.
ECHO is also now a platform for further innovation.
My hope is that with this type of technology, the quality of care to more people will increase, not just within our own country, but also around the world.
It's been so much better than I ever could have envisioned from a quality of life standpoint, from a treatment success standpoint, and just from how I overall feel. I reclaimed my life.
Welcome to our presentation on automated and clinically optimal treatment planning for cancer radiotherapy. My name is Joseph Deasy. I am chair of the Department of Medical Physics at Memorial Sloan Kettering Cancer Center. As you all know, cancer remains an unsolved and urgent problem. What is cancer? Fundamentally, it is a disease of genomic changes that leads to uncontrolled growth and dissemination of abnormal cells, such as those you see on the right. In fact, cancer is the second leading cause of death in the US after heart disease, and worldwide, there will be about 18 million new cases each year, leading to 10 million deaths. Just in the US, the effective economic loss is over $1 trillion every year. You probably know someone who's been touched by cancer because unfortunately, about 4 out of every 10 people in the US will be diagnosed with some form of cancer over their lifetime. A few words about Memorial Sloan Kettering Cancer Center. MSK is the world's largest and oldest private cancer center, having been established in 1884. Our mission covers training, patient care, as well as research and development. MSK is usually ranked as one of the top 2 cancer centers in the US. What is radiotherapy? Radiotherapy is the use of radiation beams precisely directed to disease cells to fight cancer. Radiotherapy is given to more than half of all cancer patients. Radiotherapy treatments are usually delivered in multiple treatment fractions on consecutive days. Radiotherapy has multiple uses against cancer, including curing patients by sterilizing the cancer cells and tumors, or for some patients, shrinking a tumor to make surgery safer. The state-of-the-art in radiotherapy is intensity modulated radiation therapy, or IMRT. To deliver an IMRT plan, a clinical linear accelerator, such as the one on the right, creates and directs radiation beams towards the patient with a very carefully controlled, shaped radiation field. The field is shaped by a device called a multi-leaf collimator that is located in the head of the rotating gantry. Here is a video of how the leaves move. You can see the open white area allowing radiation as the leaves move and sweep across the collimator face. The MLC leaf pattern changes to modulate the radiation, resulting in a controlled pattern of radiation dose delivered within the patient, such as what we see in the next slide. In this prostate cancer treatment plan produced using our system, ECHO, you can see the multiple beams coming in to add up and create a finely controlled pattern of dose, finding the best possible pattern of dose to within a few millimeters and a few percent for each patient is the treatment planning challenge we face every day. The problem is that personalized treatment planning is very difficult. Why is that? Because each patient and their disease pattern is unique, and each patient needs a customized plan. Planning is performed by a medical professional called a dosimetrist and reviewed by a physician. However, commercial systems typically require extensive hand tuning of the optimization parameters to control the trade-offs between the normal tissue sparing we need and the disease sterilization we need in the target volume. That results in a lot of back and forth debate about whether the best plan has been produced or should we keep trying to produce a better plan. So current methods of IMRT planning are labor intensive, time consuming, and of variable quality. That's why we created ECHO, which stands for Expedited Constrained Hierarchical Optimization. Masoud will explain how we developed ECHO based on operations research principles, but let me give you a preview of what addressing the planning problem means to MSK and even more importantly, to our patients. Compared to the alternative, ECHO is faster, less expensive, higher quality, and more consistent. So ECHO gets to the right answer quickly. There's a reduced time needed for planning and plan reviews, and there's a shorter wait for treatments for patients to the point that some patients may even avoid surgery. And we know that ECHO gives us optimal protection of the normal structures with highly effective target doses, resulting in a reduced risk of radiation-induced side effects. A big advantage is that ECHO plans have optimal quality and reliability regardless of the experience of our individual planners and physicians. While ECHO is solving today's urgent treatment planning problems, it is also a platform that overcomes obstacles and enables future innovations that we believe will further improve cancer care. ECHO will allow us to create practical workflows at scale that we can roll out to many patients that address many challenges. For example, ECHO will allow us to adapt treatments in response to patient changes, such as tumor shrinkage or weight loss. ECHO will allow us to correct for any cases of poor dosimetry in case of treatment setup deviations. And echo will allow us to directly incorporate outcome prediction models as objective functions in the optimization. For example, including predicted tumor response or predicted injury risk directly in the problem statement to guide the optimizer. None of these needed processes are currently practical at scale without echo.
Hello, I'm Masoud Zarapishe. I'm a faculty member in the Department of Medical Physics at Memorial Sloan Kettering Cancer Center, and I'm the lead developer of ECHO. My background is operations research, and I also trained in medical physics. Let me first start with a little bit of history of operations research in radiation therapy. OR techniques were used in radiation therapy even before the advent of IMRT. After IMRT was introduced in the 1980s, the medical physics community recognized the importance of operations research for IMRT. In the 1990s, the OR community became aware of this application. An interest gained momentum after a paper on the topic was published in the SIOM Review in 1999. 3 years later, Dr. Dizzy helped organize an NSF-NCI supported workshop that brought together people from the OR and the medical physics community. As you can see in this plot, since then, the number of OR publications on radiation therapy has significantly increased. There have now been more than 40 publications about radiotherapy in SIOM journals, and more than 60 publications in informed journals. Through this project, we have significantly benefited from the previous developments in the field. We have also introduced new ideas, and probably more importantly, we have clinically implemented these techniques so that patients can benefit from these advanced OR tools. As Dr. Dizzy explained, for each individual patient, the machine settings need to be completely customized. The first step toward mathematical modeling is to create a map between decision variables, including the collimator leaf movements and the radiation dose delivered to the patient. To do this, we discretize each beam into a small two-dimensional beamlets, and likewise, we discretize the patient's body into a small three-dimensional voxels. Then we pre-calculate the radiation delivered to each voxel from each beamlet for a standard unit of radiation. This provides a linear map between our decision variables, which are beamlet intensities, and the delivered radiation map that our evaluation metrics use. What makes the problem hard is that it is a multi-criteria optimization problem with conflicting objectives of high tumor dose versus sparing nearby tissues. There are multiple challenges. This slide summarizes the 6 biggest clinical challenges we had to address, along with their corresponding OR solutions. The challenges are in orange and the solutions are in blue. The first 3 challenges, which are mentioned in the letter O, have already been clinically implemented. The last 3 in the letter R have passed the prototype stage, but have not yet been clinically implemented. I'll briefly explain these 6 challenges and their OR solutions. The first challenge is the multi-criteria nature of the problem and the intense conflict between the objectives. On one hand, we would like to irradiate the tumor, and on the other hand, we want to avoid excessive radiation to nearby tissues. Our OR solution for this challenge is hierarchical constraint nonlinear optimization. It is well known in multi-criteria optimization that non-Pareto solutions are not good choices and need to be eliminated. However, there are many Pareto optimal points due to the many tissues considered. Before ECHO, the planner would assign weights to the objective functions to navigate the Pareto surface. but this often leads to iteratively changing the weights to see what another Pareto point would look like. Using constraint optimization, we can eliminate many clinically irrelevant Pareto points. For example, if the physician asks for the dose to the spinal cord not to exceed a certain amount, that can be added as a constraint. This significantly narrows down our search space. The other key is taking into account clinical knowledge that usually leads to a prioritization of the other objectives. This helps us to select the right treatment on the reduced Pareto surface. Another challenge is the non-convexity of many clinical planning criteria. For example, the clinical criterion may say, at most 30% of the lung should receive radiation dose more than 10 gray. This essentially results in a large-scale mixed integer programming problem, which is impossible to solve within our time frame. To address this issue, we have combined MIP relaxation with an effective heuristic based on the special characteristics of the problem. As illustrated in this figure, this heuristic generates plans very similar to the ground truth obtained by solving the MIP problem, but in a fraction of time. Computational complexity is another challenge. We need to generate plans within the restrictive clinical time frame. Our optimization model requires solving large-scale problems with over 100,000 variables and over 500,000 constraints. In addition, there are some modeling limitations resulting in inaccuracies. Our OR solution is to first solve the simplified and a sparse version of the problem, and then we put the plan into the FDA-approved system to get a map of those inaccuracies. We then solve a Lagrangian problem to correct the inaccuracies. We solve all the resultant problems using ample as well as the interior point method available in the Nitro solver. Now we come to the methods we have prototyped but have not yet implemented in the clinic. So far, we have modeled IMRT delivered from a few beam angles. But there is another technique called volumetric modulated arc therapy, or VMAT, in which the gantry rotates and delivers radiation continuously. This technique is more recent compared to IMRT and is a method of choice for some disease sites. Because the beam is always on in this technique, it has shorter delivery time. VMAT is about twice as fast as standard IMRT. But this is a big challenge because from the optimization perspective, VMAT is a highly non-convex and large-scale problem. We met this challenge using an advanced OR technique known as sequential convex programming. The idea, which we just published, is to solve this non-convex problem as a sequence of simplified convex approximations. This is a very general concept, and the main challenge is how to create these approximations by taking advantage of the special structure of the problem. We have shown that we can generate convex approximations in our application by restricting the collimator leaf movements at each iteration. This figure illustrates the main concept on a simple one-dimensional non-convex function. A local convex approximation on the left figure can guide us toward a local optimal solution, while a less accurate global approximation on the right figure can guide us toward a global optimal solution. As Dr. Deasy said, ECHO is a platform for innovation. Another interesting problem we have been working on is the selection of the beam angles from which the radiation is delivered to the patient. It's especially important in proton therapy where high energy protons are used instead of photons as a source of radiation. In this modality, the treatment is usually delivered from only 2 to 3 beam directions. Choosing 2 to 3 beams from the large number of possibilities is a very challenging combinatorial optimization problem. We recently published a solution showing that Bayesian optimization can be adapted to address this issue. We adapted the Bayesian optimization after listening to a tutorial presented during the Informs 2018 annual conference. We found this works very well, and that Bayesian optimization can find the optimal beam configuration by chasing down less than 4% of candidate beams. ECHO can also be used to address another challenge regarding proton therapy, which is to make sure that the quality of the resulting treatment plan is robust and will not be affected significantly by the errors and uncertainties that are unavoidable. Using robust optimization built on the ECHO framework, we can make the plans more robust against the uncertainties. This is done using the p-norm of the dose distribution as an objective function. We can then tune P to control the level of robustness between stochastic and worst-case approaches. The figures show bands of possible delivered dose volume curves for the tumor and the parotid gland. The uncertainty spread is much smaller for the robust plans in pink compared to the non-robust plans in blue. Let me summarize our research contributions. They fall into 3 different categories. First, we have built on top of OR tools that have already been applied in radiation therapy. We have also identified OR tools that have never been applied in radiation therapy. And lastly, we have created innovative tools to push the boundaries of OR to solve our problems. Putting all these contributions together, we have built a powerful and flexible platform that is now part of the clinical routine at MSK. We are fully documenting our progress in the ECHO project. Here, we highlight publications with OR terms highlighted to show the importance of OR. Now let's turn our attention to the clinical implementation of ECHO presented by my colleague, Linda Hang.
Hi, my name is Linda Hang. I'm a medical physics faculty member at Memorial Sloan Kettering Cancer Center. I'm the clinical physics lead of the ECHO project. I'm going to talk about the clinical implementation of ECHO. Making ECHO available for clinical use was challenging. To do it, we integrated ECHO to an FDA-approved treatment planning system called Varian Eclipse using their API. This enables us to ensure that the final plan is safe. We were able to create a seamless clinical workflow. ECHO is launched by a planner within Eclipse. Patient data is automatically extracted and sent to the optimization engine. After the optimization is completed, all the machine parameters are exported back to Eclipse for final calculations, and the planner is automatically notified through email that the ECHO plan is ready for review. ECHO produces radiotherapy treatment plans, so safety and quality concerns are crucial. MSK has a strong history using our own software for patient care. And as for all such projects, we perform extensive and rigorous preclinical testing and quality assurance. This is done before releasing each echo update as required for each new disease site. This is the main reason that the rollout of echo is a multi-year project. For example, we compare echo test plans to previous clinical plans to ensure they are superior or at least non-inferior. Each disease site has many different prescription schemes that may require different clinical criteria. We conduct these preclinical validation studies for each treatment regimen before clinical implementation. We also perform physics measurements and analysis of delivery at the trimmed machines to ensure dosimetric accuracy. As an example for our preclinical validation process, we compared 75 echo plans versus manual plans for patients with tumors near the spine who were treated with 3 different prescription schemes. These 3 prescription schemes have different clinical criteria. Blue denotes echo plans, orange denotes manual plans. As you can see, echo plans deliver more dose to the tumor. For dose to normal organs such as the esophagus shown here, less is better. Here, echo plans deliver less dose to the esophagus, so echo plans are superior or comparable to manual plans and shows statistically significant improvements in most quality metrics. We want to re-emphasize that safety and quality assurance are of paramount importance. The final calculations of collimator leaf movements and dose are completed in the FDA-approved Eclipse trim planning system. To ensure the safe and accurate delivery of radiation to patients by radiotherapy machines, we follow rigorous clinical quality assurance protocols. We introduced the first site for echo planning in April of 2017. Use of echo has been steadily increasing, as shown in this graph. So far, more than 3,000 patients have been treated with echo plans. Currently, we use echo to produce plans for several different patient groups. When tumors are near the spine, for metastatic disease, as well as for prostate, head and neck, and lung cancer patients. In this monthly plot of the number of echo plans used in our clinic, you can see the big COVID dip around April 2020. The COVID challenge actually demonstrated the advantage and importance of automation with echo plans, as planners and physicians needed to work remotely, but echo made generating high-quality plans reliable and efficient. Our clinical experience has been that echo is easy to use and produces consistently high-quality plans independent of a user's experience. At this point, echo is producing about 15% of all plans. We are expanding echo to more disease sites and expect to produce about 80% of all plans at MSK via echo by the end of 2022. Echo has had a great impact in our clinic, and we expect it will have a strong impact outside Memorial Sloan Kettering Cancer Center, especially in resource-limited countries. According to the International Organization for Medical Physics, more than 75% of countries lack qualified radiotherapy treatment planners. The clinical criteria built into ECHO represents MSK's vast knowledge of radiotherapy treatment planning. Thus, ECHO is a platform to share MSK's institutional knowledge. Although ECHO criteria need to be modified by other users, this is straightforward. ECHO is currently integrated with the widely used Varian Eclipse clinical treatment planning system, but it can also be integrated to other treatment planning systems. Now that you have heard about the technical and the clinical implementation aspects of ECHO, let's hear from our treatment planners about their experience using ECHO.
Hello, my name is Rene Brito, and I'm a treatment planner. I work on many plans for a variety of patients every day, often under pressing clinical deadlines. Without ECHO, planning is a trial and error process, and I often wonder whether I could further improve the plan quality if I had more time. Because ECHO can generate a plan in the background, usually within an hour, team members can work simultaneously on other patient treatment plans, thereby increasing efficiency. When the plan is finished, given its high quality, it will easily be approved by the physician.
Hi, my name is Alex Kowalski. I'm a treatment planner at Memorial Sloan Kettering. And what I really appreciate about ECHO is its flexibility to handle complex clinical situations. Each patient is unique, and sometimes a physician may have extra considerations that further complicate the plan. For example, if a patient only has one kidney, the physician may ask for extra protection of the patient's remaining kidney. In such a case, finding the optimal clinical trade-offs for these patients is often complicated. ECHO can easily accommodate complex situations and provides transparent trade-offs between normal tissue sparing and tumor coverage. ECHO makes complex problems simpler.
Hello, my name is Yingzhou. I'm the Senior Clinical Radiotherapy Physicist at Memorial Sloan Kettering Cancer Center. As part of our quality assurance process, I double-check the quality and safety of the plans generated by treatment planner before they are used to treat patients. I mainly rely on the established clinical criteria and my over 15 years of clinical experience to judge the quality of plans. Having seen so many ECHO plans in the past 3 years, I'm confident in their quality, which makes my plan checking job much easier and less stressful.
Hello, my name is Niril Shah, and I'm a senior radiotherapy physicist. I lead a team of planners who perform expedited radiation treatment plans for clinically urgent situations. Automated ECHO treatment planning has greatly reduced the burden and pressure on those team members who are producing patient treatment plans on a shortened timeline. ECHO has allowed us to reduce the timeline of the treatment planning process from start to finish for many more patients than would have been previously possible. It's been an enormous benefit for those patients who, based on their radiation oncologist's recommendations, have an urgent need to begin their radiation treatment. Overall, ECHO has greatly improved our clinical workflow without sacrificing treatment quality or safety. Now that you've heard about the clinical impacts of ECHO, let's hear from Dr. Josh Yamada regarding the impacts on patients.
Hello, I'm Josh Yamada, radiation oncologist at Memorial Sloan Kettering Cancer Center, and I work in the Department of Radiation Oncology. I also serve as co-director of the Spine Oncology program at Memorial Sloan Kettering. More than 2,000 patients have been treated with ECHO planning at Memorial Sloan Kettering Cancer Center. ECHO treatment planning has provided some important real-world benefits for patients whom we treat. Beyond consistently providing very high-quality treatment plans, the significant reduction in time needed to provide these plans has been game-changing for our patients. In the past, the suitable treatment plan often required at least a week to develop, while with ECHO planning, this has been reduced to just hours. Patients with spine tumors often suffer tremendous pain, and patients no longer need to wait an additional week in agony waiting for their treatment plans to be prepared so that they can start treatment. And in urgent cases with ECHO, we now have the ability to provide same-day treatment. In the days of pre-ECHO, Patients with advanced spine tumors who couldn't wait for the treatment planning process because of concerns about tumor growth and progression during that wait, but were otherwise good candidates for spine radiation, were often taken for spine surgery instead to circumvent catastrophic tumor progression during the wait. The time savings of echo planning have allowed these patients to forgo back surgery and proceed immediately to radiation. The echo planning has also made it feasible to treat patients who require both surgery and radiation to receive radiation preoperatively, a much more efficient way to treat spine tumors, rather than postoperatively, even when surgery is urgent. This allows patients to recover from surgery and then be discharged directly to home or for rehabilitation, and eliminates the need for preparing for radiation while recovering from back surgery. In cases where chemotherapy is indicated after surgery, patients receive the radiation prior to surgery also need not delay the start of chemotherapy for postoperative radiation treatment. This time savings has also impacted patient care in other ways. For example, patients with severe back pain requiring hospital admission had to wait for their treatment plans to be created and remained admitted to hospital for no other reason than waiting for the radiation treatment to start. Being able to expedite treatment planning with echo and reducing otherwise unnecessary hospital admission stays is not only better patient care, but provides and improves efficiencies in hospital stays and inpatient care costs. Now let's hear from Dr. Lisa DeAngelis, Memorial Sloan Kettering Cancer Center's physician-in-chief.
At MSK, we believe in continuous innovation when it comes to cancer care. Together, our radiation oncologists and medical physicists have developed cutting-edge operations research methods to efficiently determine the highest quality treatment plan for each of our patients. For decades, this complex problem went unaddressed by the medical community and its commercial partners, mainly because of the interdisciplinary and mathematical nature of the problem. Now, thanks to Dr. DC and the remarkable team he has assembled, we have ECHO, an automated system that reliably determines the best possible treatment plan for a given patient in a shorter amount of time. This personalized approach provides a new level of benefit for our patients, not only because they are receiving a more precisely tailored treatment, which we believe reduces the risk of side effects, but also, and this cannot be overstated, because ECHO eliminates the risk of human error and variability. ECHO is also an invaluable asset to our employees and institution, as it frees up our physician and treatment planners to improve care in other areas. Our multi-year commitment to improving radiotherapy by using operations research methods has paid off remarkably for both MSK and our patients. And the impact will only increase as ECHO is applied to a broader range of treatment indications and innovations, and ultimately to the world outside MSK. Congratulations to the team, and thank you to Informs for recognizing this tremendous effort.